A couple of Zoom reminders. You'll be muted when you join the session, so please just stay muted until we do Q&A. And we do want to hear your questions, so go ahead and put them in the chat as they pop up, and then we'll address all the questions at the end of the overview. And please do note that the session is being recorded for those that couldn't attend in person today. If you're new to Zoom, there's some screenshots here that show where your microphone and your video and the chat box are. Again, please mute your mic when you're not speaking. If you're joining as a group or a team, it would be helpful if you could chat who else is with you in the chat box. So whoever registered for the webinar and then whoever else is joining you. And now some background on the Alliance and our Esper work. We are the School-Based Health Alliance, and we work to improve the health of children and youth by advancing and advocating for school-based healthcare. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students already spend the majority of their time, in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed. Behavioral health issues get quick, expert attention. And we all know that healthy students make better learners. So again, my name is Katie Stenchfield. I'm a senior program manager with the School-Based Health Alliance, and I lead the SBIRT-in-SBHCs project. Samira, Sarah, and Emily, members of our project team, will also join us for a Q&A. And I apologize because I neglected to put Sarah's name on the slide, but thanks for joining as well, Sarah. Brief overview of what we're going to cover today. And special thanks to the Conrad Hilton Foundation for funding our work. Here's some background on our SBIRT work. We've been doing SBIRT in school-based health centers for the past 6 years, testing the adaptation of adolescent-specific SBIRT nationwide in school-based health centers to inform a strategy for large-scale implementation and training. And Emily has chatted the link to our initiative webpage if you'd like to check that out. That also includes our newest infographic, which we just put out in May, that describes the rationale for SBIRT in school-based health centers, as well as our current project goals and objectives. This training and implementation opportunity being one part of our overall SBIRT initiative work. We're going to dive into the RFA now, and I'm assuming most of you have seen it, but if not, Emily has also chatted that link in the chat box if you'd like to look at the document itself. We'll go over all the sections now. So the purpose of the funding is to create this learning collaborative that will support school-based health centers nationally in preventing, identifying, and reducing substance use and depression in middle and high school age youth. We address several key topic areas that we've had requests for assistance from the field: depression, substance use, youth engagement in healthcare, and restorative justice alternatives to discipline. So we're working specifically on SBIRT, but we have many layers to our SBIRT work. And in light of the COVID-19 pandemic, we're also looking at changes in provision of care to support telehealth implementation if that's a fit for sites. We'll be funding 8 to 10 school-based health center sponsor organizations and their affiliated school-based health centers for a one-year collaborative. Some benefits of participating are not only working on SBIRT implementation, but working on overall school-based health center quality to create a good foundation for SBIRT. Access to our national array of expertise and networking, including the network we'll build through the learning collaborative of peer sites implementing SBIRT. As expert faculty and technical assistants to work on all the different topics for implementation, including telehealth, depression screening, billing, coding, EHR modification, youth development, quality improvement, and school and community collaboration. And we'll also be providing access to the NORC Adolescent SBIRT training curriculum, which is a very robust and thorough curriculum for implementation. And then in alignment with that, sort of supplementary, the Cognito Avatar role play simulation training, which is a pretty cool way for providers to practice providing SBIRT using avatars online. We'll also provide the Teen Intervene curriculum, hoping to build treatment capacity within the school-based health center itself. And that will, that's a over $400 value, I think. So that's another benefit. And then we'll use many different technology platforms to work with our collaboratives. So that will include Zoom and Basecamp and some others. Working with you to implement SBIRT as an alternative to suspension if you are a site whose school partners are prepared to collaborate on something like that. And there's also a financial incentive of $5,000 for full project participation. Originally, pre-COVID, when we set this grant up, we required you to use part of your subgrant to attend the national convening to kind of wrap up the project. So more on that later, but obviously that is pending the health situation in the country. Again, the Cognito training is a benefit, role-play simulation, and it includes CEUs, the Teen Intervene curriculum. Basecamp is a real-time online communication platform that helps all of us stay on the same page and share resources, pretty robust way to communicate. And then again, the NORC Learner's Guide to Adolescent, SBIRT curriculum, and we'll be using the Project ECHO model, which if you're not familiar with it, I'm a huge fan. The ECHO philosophy is this idea of all teach, all learn. I've heard it described for medical providers as something like a virtual grand rounds. So it's, to be really clear, it's not a webinar. It involves not only presentations by experts, but also really in-depth case presentations from peer sites. So everyone participates every session. You'd be using cameras, you'll be interacting with each other and not only receiving that expert input, but also supporting each other and providing feedback and resources to one another as we all learn together. And we will record those sessions, just a heads up, because we use them to build out our future tools and toolkit. So in terms of who should apply, we would like organizations sponsoring school-based health centers who are interested in implementing SBIRT in their school-based health centers, including via telehealth, assessing school-based health centers on key measures of overall school-based health center performance, as well as SBIRT implementation. So again, those foundational pieces. Incorporating a youth development approach in their work, and potentially using SBIRT as an alternative to suspension. And you would need to be the sponsoring agency of at least 2 school-based health centers providing and billing for primary care and behavioral health services in a middle or high school setting, a minimum of 20 hours per week. So the key thing is that we want to have that linkage between primary care and behavioral health for treatment. And we are not particularly tied to what that looks like as long as it's functional. So you'll see the note that even if your behavioral health is provided by a partner organization, that's fine. We just need the appropriate MOU, etc. You must be using an electronic health record system, and you should have an established partnership with the school district that you'll be working in, have access to in-house technical support for data entry, reporting, and EHR modifications. We've found that that's very key. We can't pop in and retrofit your EHR, so we need somebody on the inside who has that capacity. And you must be a current organizational member of the Alliance. I added this note to the presentation today. It doesn't say this in the EHR, but I wanted to call this out specifically, that we expect to use Zoom a lot. We expect people to be on video, so you need to have the appropriate technology to participate fully. So cameras and microphones, and also your agency or organization's permission to be using Zoom and other technology platforms that we'll be using. So be sure to check on that. I think largely in our field, people have that permission, but I know some federal sites don't. So just check on that. And just looking ahead to, if you want to use telehealth, you'll need these resources as well. Just a brief overview of what we would be looking for in your EHR to collect. So this is where the modifications would come in, and this is the data we would want to collect from you. So number of unduplicated clients, numbers screened for depression and substance use, numbers with a positive screen, brief intervention, number of visits, visits with screenings. So we can dive into this more on the Q&A, but I just wanted to give you an overview of what we would be looking to collect. And now our timeline. So the application is due July 23rd. We're happy to help with any questions, so feel free to reach out. By August 2020, we will select sites and notify them of acceptance. We'll issue letters of agreement for selected sites. We'll have a welcome webinar, and the selected sites will complete their pre-initiative assessments and action plans. And then between September and November, we'll kick off our training using Project Echo. And sites will do case presentations during these 6 trainings on an overview of their site, introductions, and their action plans. And then during that time, you guys will complete the virtual SBIRT training using Cognito, and you would be simultaneously training your sites using that NORC curriculum. So during the fall, we'll provide our training, and then you would be taking this back to your providers and helping them get trained as well. So there's that supplemental work. And then we'll work on EHR modifications and do test runs for reporting the data. And then we'll do a brief midpoint survey, and we'll have a scheduled check-in with each sponsor change team and the Alliance team. And then from December to May, again, we'll have 6 more trainings. Those case presentations, sites will focus on their progress on SBIRT implementation. And again, it's meant to be a collaborative learning process. So it's not a, we never expect you to have it all figured out right away. We really want to meet people where they are and work on progress over time. And then we'll be, you guys from December to May, you'll be sending in aggregate data monthly to the Alliance. And we'll do our final assessments. And then in June, all fingers crossed, at least one sponsor change team member will attend the endpoint celebration for the project at the 2021 National School-Based Healthcare Convention in Atlanta, fingers crossed. And sponsor change teams will send their final aggregate data to the Alliance. So a couple just sort of side notes. Our original SBIRT work, we assumed that school-based health centers were sort of foundationally solid in their processes and how they were providing services and how they were collaborating with partners. Because laying SBIRT on top of all of that, especially with some of the additional activities we'd like to do, such as youth development and alternatives to suspension, you really need those strong foundations. And what we found is that, you know, different school-based health centers are in different places, and that's fine, but we really needed to do some work with certain centers on building that school-based health center foundation. So one thing that we'll do in this cohort is spend some time assessing, you know, based on our known core competencies for school-based health centers, where are you at and how can you improve in order to be able to add the SBIRT piece successfully. Also, the importance of being realistic. I think, you know, I think that sometimes we have folks who are really excited about something like using SBIRT as an alternative to suspension, and that can be amazing. We've had really great success in some areas with that, but for that to function, again, you have to have those really strong school partnerships and those sorts of things. So just being realistic about where you are and what's possible. And again, we'll sort of walk through that process with our self-assessments and those tools as part of the learning collaborative. And I believe I've already talked about this, but having integrated behavioral health, because we really want to offer, to the extent possible, in-house within the school-based health center treatment. Obviously, depending on levels of use and need, you may need to refer out, and we'll want to develop those networks as well, but historically adolescent treatment is limited and not always developmentally appropriate. So we want to build in kind of that continuum of care that we have resources within the school-based health center for treatment when appropriate. And again, I've talked a bit about the technology already, but there will be, you know, lots of video interactions and again, strong collaborative interaction with peers. So we really need you to have your video cameras and all your tech functioning appropriately. It's not a passive activity. It's definitely a all hands on deck, everybody engaged type of project. So again, we will notify selected applicants by August 3rd. And that is all I have for you. I'm going to open it up for questions. Go ahead and you can enter them in the chat box or unmute your mic. And I think I'm gonna, yeah, I will keep an eye on the chat box. Let us know your questions. I'm not seeing any in the chat box yet. Feel free to unmute your mic if you'd like to just ask your question verbally. I know I missed something, you guys. I'm not that good. There's got to be some kind of question.
I have a question. Can you hear me? We have 9 school-based clinics with 8 in elementary school, 1 new one in middle school. We just moved into middle school and hope to expand into high schools next year. So I think it'll be that they're doing construction and all that. It's always a moving target as to when we would actually get into the high school. But what I'm hearing from this is we probably wouldn't be eligible because we just have the 1 middle school site currently.
So sorry, you said you only have 1 middle school site open?
Yes.
And no high school sites open?
No, I can't imagine they're going to have them open. We have 2 high schools we're supposed to move into, but they're still under construction. And with everything that's going on in the school system, I wouldn't see us in there this year.
Yeah, so I think, but you know, all of these expectations, so this expectation that we have 2 school-based health center sites, we can be tentatively flexible, I guess I'll say. If you have 1 site that you can work with now, and you foresee opening another one and can sort of start training, you know, it sort of depend on the level of engagement. If you can start training those providers and kind of work towards that for when schools reopen, whether that's kind of the way things functioned in the past reopening and or in different telehealth or other capacities, we would be willing to consider that. So I think like I would be interested to hear sort of what you believe the timelines would be, what the capacity for training would be, because really what we're doing here is training the sponsor change team, providing an array of resources so you can go out and train your providers. So it would sort of depend on when those sites would be opening and what that is all going to look like. So I'd be happy to kind of review that on a case-by-case basis. Obviously, I know there's lots of things we can't control in the world right now, so we want to be adaptive, but we also do need to collect data and be able to share that with our funders. So maybe follow up with me one-on-one if you have kind of a special case like that, and I'm happy to look at what that might look like.
Great, thank you.
You're welcome. I see someone said, is the session recorded? The session is recorded, and we will post both the recording and the slides on our website after this session. So you will have access to that. I see a question that just says, talking about technology problems. Can you clarify what the program? Issues because of technology program. So I think you might be referring to my little public service announcement, just saying that we really need the participating sites to have access to appropriate technology. So obviously computers, webcams, microphones, to be able to participate fully in, you know, something really similar to what we're doing right now, using Zoom, being able to see each other, being able to talk to each other. If that does not answer your question, let me know. And then I see another question. What role or position do you think is best to supply the information you are looking for? Can you clarify that question for me, Pamela? Do you mind unmuting your mic?
So are you looking for like a navigator, a social worker, a psychologist, a psychiatrist, a nurse practitioner? Who is it that you think is best to supply the substance or the content of the information that you need?
And Pamela, do you mean to write the application for this project, or during the project to be able to?
During the project, collecting that information.
Yeah, so you would form a sponsor change team, and again, I know that might look different at different sites, but that might be primary care, behavioral health, someone with some oversight over the school-based health centers, but it needs to be someone who's in a position to attend all these meetings that we talked about, the 6 in the fall, the 6 in the spring, collect all the training information, oversee disseminating that to the folks you're training. So whoever's going to be providing the screening and follow-up services in the school-based health centers, be able to essentially, it's sort of a train the trainer. So the person that would be attending all of these, or the team that would be attending all of these trainings, would then be taking it back to the providers. And we are flexible in that we know different school-based health centers operate different ways, have different staffing setups. So we would be, open to what that would look like, as long as you have that integrated primary care and behavioral health piece. We've had very many different combinations. So does that answer your question?
Yes.
And let's see. So it says, when you spoke about substance use treatment in schools, what does that look like for most schools? We have behavioral health in our school districts and primary care in 6 of them. So it looks different ways, different places. We are, our approach is certainly to move away from anything related to like zero tolerance, those sorts of things. We also understand that, school-based health centers in a perfect world are partnered very strongly with their schools and working really collaboratively together. We know that that's not always the case. So I guess best case scenario, what we would be looking at is a really collaborative process between the school and the school-based health center, where if a young person has an offense or gets in trouble for substances, having them on campus or using them or whatever, that instead of it being kind of a one strike you're out suspension, that it would actually be a referral to the school-based health center, some prevention education, screening, those sorts of things in a confidential manner. So you're not reporting it back to the school administration, you're not giving them access to young people's personal information, but really framing early substance use around education and helping them establish healthier habits. Now, if it's the 17th offense, it might need to look a little different, and we understand that. We also understand that the school-based health center doesn't get to decide school policies, but if you want to use SBIRT as an alternative to suspension, it's something that we would be very happy to help with and support. Again, the school has to be open to kind of looking at it that way, having a more restorative practice, frame of how they're handling youth discipline issues. I can definitely say that if your school-based health center is doing like some schools do, like randomized drug testing. So if your school-based health center does random drug testing for the school and then reports those results back to the school, it's going to be really hard to sell alongside that SBIRT as an alternative to suspension, because young people are seeing you as kind of an agent of the school that can get them in trouble. So just want to be thoughtful about those processes. And then when we look at like what the treatment will actually look like, again, that's why we selected, there are lots of different evidence-based programs out there. We selected Teen Intervene because it's a curriculum that has worked well in school-based health centers. So it's a several session intervention that can involve a parent if that's a good fit. And it's manual based, so it's very easy for providers to sort of pick up and use. And that would be, Teen Intervene would be a fit for mild, potentially moderate use. If you need someone with, inpatient detox type level of treatment, it's not a fit for that. So we'll be referring out of the school-based health center for that. We do have, if folks are interested, we have some school-based health centers that are actually engaging in medication-assisted treatment. That's not a part of this project, but we're seeing some pretty robust treatment options in schools if folks are interested. Let me know if that didn't answer your question. So how much additional workload does the screening aspect of SBIRT put on SBHCs? How have other school-based health centers implemented screening in a way that isn't too heavy on time and resources? So this is a tricky question. In pure form, SBIRT is meant to be a very brief interaction. The screening can be completed outside of the session, you know, like depending on site capabilities, on a paper form in the waiting room, while they're waiting in the exam room. Different sites have different technology, so potentially completing it on an iPad or something like that. So the screening doesn't need to take up session time. Then the brief intervention is intended to be just that. We really promote in the school setting that no matter, even if they screen negative, that you really have a brief conversation, a couple sentences sort of discussing the need for, you know, just sort of some education around substance use, even if they screen negative, you know, affirming their positive choices for their health, that sort of thing. If they need a brief intervention, again, it should be a very quick conversation. And then if they have screened, you know, again, on the moderate to higher level of use, brief intervention referral to treatment would be a slightly longer process, but our goal is to really train folks to handle this in a really quick and efficient way. And that's part of why we're using the Cognito avatar training, is to give people actual practice at going through the steps and doing it efficiently. All of that to say that this is sort of the catch-22 of SBIRT. To bill for SBIRT, it often has to be in a 15-minute increment, which does not fit with our efforts for it to be an efficient and sort of easy to add into the session. So that's something we'll dive into later within the training cohort, is sort of how to navigate that. Different people have done it different ways at different sites. I think the key thing for us is to really think of SBIRT as a best practice. So along with many of the other things you would do at a primary care visit, such as checking weight, checking blood pressure, those sorts of things, like considering SBIRT that way, that it's a major health indicator that's a best practice to include. And then always juggling the time. But we can talk to some providers who are doing it well. We'll invite them in and connect you with them, because I think there's some good resources out there for how to make it effective. And again, if I'm not answering your questions thoroughly, please let me know. So it says, what specific expectations does the funding have for the mental health clinical supervisor? We don't have specific funding for specific roles. The sub-grant is just, again, there's all those project expectations. Once you've completed those, we would issue, I think, partial payment of your sub-grant mid-year, and then the other payment at the end of the year. So Oliver, feel free to chime in if you have a more specific question than that. I don't hear you, Oliver. So, nope. Okay. yeah. So no specific, you know, expectations by role. We just want to have those different roles represented in the sponsor change team. And thanks for that note too, Oliver, about the time frame for SBIRT. Those are all the questions I see in the chat. Are there any other questions folks have that you want to say? Unmute your mic and say out loud, or put in the chat. And if Samira, Sarah, Emily, if I missed anything, feel free to chime in as well. What is the age of youth that we're targeting for this program? So we've just generally said middle school and high school. I think the youngest we would look at is 12 don't quote me, but I believe that that is what at least one of our screening tools is normed to. So I don't think we'd want to go younger than 12. But yeah, generally middle school and high school age populations. And I think the thing that you'll see for those of you working in school-based health centers, this is probably old news, but a lot of these screenings, a lot of what we'll see frequently in schools is that many young people screen negative. You know, they're not using yet, especially in the middle school setting. They haven't even tried it, but some research shows that just asking those screening questions early and doing that sort of brief advice or anticipatory guidance interaction following that screening, coming from a health provider, not a parent, not a principal, can really have a positive influence on young people choosing not to use or having kind of a risk reduction effect. So that's sort of why we look at doing it even in middle school. And just another note, when we did this in the past, we actually required an IT representative for the sponsor change team. We've gone away from that just to limit how much time we're asking folks to commit and how many people we're asking you to pull in for every meeting. But it is really important to have that strong relationship with your IT support so that you can get those EHR modifications made. And again, some places, it looks different places. I know some school-based health centers have this super robust IT department and they can get changes made rapidly and it's all very functional. And then, I've definitely worked with sites a lot that, it's like the nurse practitioner who got trained in the EHR and is the one who makes all the modifications on top of their already busy workload. And it can look a lot of different ways. So we just want to make sure that whoever that person is, that we have them on board and able to make those modifications fairly efficiently. Right, any other questions? I'll give you guys a couple more minutes to put them in the chat or unmute your mics and share. All right, I just changed to our last slide. Thank you so much for coming today. We are happy to answer any further questions. I know that this is clear as mud, so feel free to email me, happy to work with you. Like I say, we really appreciate that all school-based health centers look different, not to mention that the whole world of schools and healthcare looks so different now. So we're very happy to work with you to figure out how to make this functional for your sites. Feel free to reach out. Thank you so much for joining us today.
Katie, I think one last question that came in. No, yeah.
Oh, I apologize. Thank you guys. So we're a team. So it says, I know there are a variety of experts available. We have one built into our EHR. What will this program use? Do you mean, Corby, do you mean screening tools? Yes. Yeah. So we have gone to letting sites choose. There are several different validated screening tools for adolescents. Likely the most commonly used is the CRAFT. Some sites use the S2BI. There are a couple of other options. So we want you to choose what works best for you. And that's why, if you remember that EHR data slide, we're not asking for sort of exact like CRAFT results. We're just asking for numbers around those. So that hopefully, again, if it's already built into your EHR, like that's pretty handy. So maybe you want to go with that one, or give you kind of an opportunity to pick and choose what works best for you. There are pros and cons to different ones, and that's definitely something we can go over to as we dive into training with the cohort.
Okay, I might just add one clarification for the EHR. When we say modification, some of these fields are already built in. So there some sites, as Katie said, if your EHR is already pretty comprehensive, you don't have to make any modifications to track some of the data that we're looking for. It's, like the client screened, the results, whether they're positive or negative, and then if they received intervention. What may need to happen though is some programming to pull those data out for reporting. So just want to make sure we also bring that up as far as modifications. It may not be a modification to the actual fields in the system, but it might be working with IT to develop a report so that you can pull data out on those specific fields.
Great point. Thanks, Samira. Yeah, and I think that's evolved a bit since we started this work, where we very few of the EHR systems early on had these things built in, and now you're seeing more and more that they are built in and they're not an added cost or anything like that. So that's a great point. Yeah, that hopefully we don't have to work as hard now.
Yeah. Do you want me to take the next question that just came in, Katie, from Oliver? We use some measures to track progress. When you say duplicated, do you mean the first screening? And when we want unduplicated clients screened. So we just want to know if the clients received one or more. So at any point, did they receive a screening for substance use? At any point, did they receive a screening for depression? Knowing that sometimes students will get more than one screening, but the unduplicated count comes in with us just in terms of how many of your clients that you serve had one or more screenings. I hope that makes sense. And then how would you track subsequent screenings? So again, we don't need to know how many times each client was screened. We just would like to know that every client received at least one screening. We do have the caveat is that we do ask how many visits included screenings. So that's where we would get the counts overall of how many screenings were provided by your clinic. But in terms of just, we just want to know that the goal being that every client who comes in for a primary care behavioral health service is screened for substance use at least once during the year. So Oliver, you're sharing that every client receives screening and then you track the number of visits. Yep, that's perfect. So you would, it sounds like you would be able to tell us the number of clients that received at least one screening and the number of visits that included a screening. And these are all aggregate numbers, so we don't need data on individual level. And the reason we ask for them monthly is with the intention that as you're building building your clinic's capacity to implement SBIRT, that those screenings are going to increase over time. So we'll follow the numbers each month to see, like in January, there were 30 screenings of our clients. In February, we have a cumulative 60 clients screened, and hopefully those numbers over time will increase as SBIRT is integrated more and more into clinic practices.
Thank you so much, Samira. And I think just to call that out again, I think another major benefit of participating in the project is just this access to expertise. So we have our amazing evaluation consultants, Sarah and Samira, who obviously have a great deal of expertise in this field. They've worked with us every step of the way on this, as well as a lot of other expert faculty from around the country, and just a huge array of experience and resources for you. And I think that's one thing I would say is that if you're considering participating in the project, I know everyone's busy, there are lots of competing demands, but for the year that you would participate, we will have our scheduled trainings, we'll have requirements for you, but you also would have access to all of these incredible experts, and really encourage you to reach out to them. Again, we'll have our scheduled time, but this whole year, as you would be working with us, we would be available to help figure all of these things out with you. So I think that's an incredible benefit, and I really encourage people to use it, because I think sometimes people are shy about reaching out and asking questions, but that is what we are here for and what we love to help with. So just a little side thought.
And Katie, can I have one side thought? I know we talk a lot about the data, and I just want to make sure that that's not a deterrent to anybody applying for this this grant. The programming and as Katie said, the expertise that you would receive are invaluable, and don't let the data requirements stop you. We are really flexible and want to work with you to be able to pull out data, and it should not be a burden. We're trying to keep the measures that we're reporting to the funder to those that we've seen are pretty easy to get out of EHR. Again, they may already be existing in EHR, or they may just involve some programming to pull them out in reports, but please don't let the EHR data requirement be a deterrent to applying. We'll work with you on that piece.
Awesome. Thanks, Samira. All right, any further questions? Give the chat box a little more time. Feel free to unmute your mic. Again, if we've come up with anything today that feels like a deterrent in applying, please do reach out and ask, because again, we're all adapting to the new COVID-19 world, and we are fortunate in that our training model currently for SBIRT is all virtual, so we can provide a lot of resources virtually. But we know that there are just lots of new considerations. So if you have any questions or anything that seems like a barrier to applying, please definitely reach out, and we'll do our best to work with you. And we really hope to see everyone's application. I don't see more questions. Again, my email is on the screen, so feel free to reach out and we will help with anything that we missed today. All right, everyone, I think we'll end there. Have a great day, and thank you so much for joining us. Again, the recording and slides will be on our website shortly.